So kia ora koutou. Welcome to the first lunchtime webinar for 2021. And today's presenter is Murray Hart, who's in Christchurch. And today Murray's going to present on congestive heart failure. Murray is clinical nurse specialist in the cardiology unit at Christchurch Hospital, and his role encompasses a coronary care unit, cardiology ward, and the Cardiac Cath Lab. In addition to his CNS role, Murray is coordinator for the TAVI program. Now that's the very cool procedure where totally collapsible heart valves are introduced into exactly the right place through a catheter, I think. It's really quite something, isn't it? And Murray's background experience includes nurse education, which he obviously has a passion for, and cardiology research. And today Murray's going to be talking about classification, both old and new terminology, clinical presentation, diagnosis, overview of management, and essential patient education. So before I hand over to him, I'd just like to remind you to use your Q&A function to write questions. Murray will like to see those questions as they come. It helps him to be more interactive. And could you set your chat function to all panelists and attendees and use that one to introduce yourselves? Thank you, and welcome, Murray.
Thank you, Pauline. Thank you, everyone. Welcome, everyone, to this lunchtime webinar. This is a fantastic medium to have education with, especially in these COVID times. No matter what level of restriction we're in, we can still have education in this way. And the advantage of it is, if it doesn't suit you to be able to log in live now, you can watch this through the mobile health solutions site afterwards. There's a couple of questions that I'm going to prepare that'll give you CME points. So wonderful way that we've got to provide education these days, and thanks to Mobile Health Solutions, thanks to Pauline for moderating today. So I was asked to talk about congestive heart failure, and one thing I always sort of promise to do at the start is to finish on time, and I think it's especially so for a limited time like this, a lunch break time. Many of you will be on lunch break, and clearly the advantage with this is that you can come and go as you need to. If you're listening at home, you can put your feet up, have your dressing gown on, have a coffee and relax and enjoy. I do encourage you just to have a wee look for the question and answer function button. There will be just a couple of questions that I'll ask when I go through. And remember, you can just type in your questions as they come up. You can type in questions. This is totally interactive. So as Pauline said, what I'm going to cover just is a little bit of broad outlook in how we classify heart failure. So the topic is clearly congestive heart failure, but there's a couple of other classifications that we should talk about. And one of them is a very new classification for heart failure. And we now classify heart failure with either heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. And don't worry if they're new terms to you, because we'll cover them a little bit later as we go on. We're going to talk about clinical presentation, how people present clinically with acute heart failure, how we diagnose it, give you a little overview of the management, including a new heart failure medicine. So I always love being able to share what's new in the management of heart failure, and then finish off with what's really essential for you as a health professional in terms of patient education, because this is all about improving patient outcomes, isn't it? And how do we improve patient outcomes? We do it by diagnosing, managing patients well, and providing self-care patient education. So that's what we're going to cover as we go through. And really, heart failure can be as simple or as complex as you want it to be. And really, very simply, heart failure is pump failure. It's failure of the heart as a pump. But, you know, in cardiology, we love to call things under multiple terminology, but really that's sort of one and the same thing. And I'm going to talk very shortly about the ways that we classify heart failure, but it's all really the same pathophysiology, isn't it? Often when we talk broadly about heart failure, we make this assumption that we're talking about left ventricular failure. because the major muscle area of the heart is the left ventricle. And so the assumption often is that we're talking about left ventricular failure. And that's true for part of the time, but this diagram here shows very clearly the difference between the left and the right side of the heart. You've got the lungs in between, you've got the periphery. So there's a number of other components of this whole system or cycle that can cause problems and can contribute to heart failure. So it's not all about the left ventricle or about left heart failure. So some of the terms that we've talked about in the past especially have been left and right-sided heart failure, and we still use those terms. We still use that terminology. When you combine left-sided failure with right-sided failure, what do you get? You get congestive heart failure, and that's what we're really here to talk about this afternoon, is congestive heart failure. And very simply, congestive heart failure is heart failure where there's volume or fluid overload. Whenever there's heart failure or pump failure, there's two issues, and one is there's problems with forward flow of blood. So because the pump is weak and failing, blood can't be pumped forward as efficiently. And also there can be problems with back flow. So there's forward issues and there's backward issues. When we talk about left-sided heart failure and the problems related to forward flow, because the pump is weak, because it's a pump failure, the amount of blood that's ejected or pumped out in one beat is reduced, and we express that as a percentage, and we'll talk a little bit more about it later. It's termed ejection fraction. But as that goes down with left-sided heart failure, then blood pressure will go down, and also the amount of oxygen and nutrients supplied to the tissue also goes down. So that's some of the problems with reduced forward flow. A lot of the major problems with left-sided heart failure are related to back pressure. So when the left ventricle becomes full of fluid, and we can see it in our little diagram here, when the left ventricle becomes full, then it goes back to the left atrium, and when the left atrium's full, where does it go back to? It goes back to the lungs, doesn't it? And so you get fluid in the little alveoli sacs, you get fluid on the lungs, and of course we have to have a big word for that. We call it pulmonary edema, don't we? So one of the issues with back pressure with left-sided heart failure is the potential for pulmonary congestion or pulmonary edema. You know, I just appreciate teaching simple concepts, and with heart failure, with left-sided heart failure, you know what happens to the left ventricle? It becomes bigger, it becomes thinner walled, and it becomes weaker. So if you want to sum up heart failure in 3 words to your patients, that's what happens. The heart enlarges, so it becomes bigger, but when it becomes bigger, it becomes thinner walled, and with that, the pump becomes weak. But you know, we always have to have complicated terms. And so if you read literature around heart failure, you'll see this term left ventricular remodeling. So left ventricular remodeling is really the left ventricle becoming bigger, thinner walled, and weaker. It's as simple as that. But we should also talk about right-sided heart failure, because we've seen that the right side of the heart is a component of this whole cycle and system. And you know, the right side of the heart is often referred to as the neglected side of the heart, and right-sided heart failure is often the neglected heart failure. So we talk a lot about the left-hand side of the heart and the left ventricle and left-sided heart failure, but often the right side of the heart and right ventricle is a little bit more neglected. So let's just look at the right side and talk about right-sided failure, because remember, if you get left-sided failure and right-sided failure, then you've got congestive heart failure, which is the topic this afternoon. So the right ventricle and also the right atrium can dilate and get bigger and thinner walled, just the same as the left ventricle. And so the right ventricle, the function of it, and the right atrium is to receive blood from the top of the body and the bottom of the body from the inferior and the superior vena cava. So it enters into the right side of the heart, and then it's pumped out through the pulmonary vein valve to the pulmonary arteries and the lungs. So that's how the right side of the heart works, pumping it to the lungs. And very simply, for patients that develop right-sided heart failure, there's three main causes. One is that there's too much fluid, so we call that volume overload. Sometimes the pressure inside the right side of the heart gets too much, we call that pressure overload. And thirdly, sometimes it's related to disease. So what sort of conditions can lead to volume overload? Well, if there's a hole or a defect in between the left and the right atrium, that can cause volume overload. If there's a problem with the tricuspid valve, and remember the tricuspid valve is the valve between the right atrium and the right ventricle, that'll cause volume overload. You know, we had a combined cardiothoracic cardiology team meeting this morning, and one of the patients we discussed has a problem with his tricuspid valve. So any valve problem, any tricuspid valve problem can lead to volume overload and lead to right-sided heart failure. What are some of the conditions that lead to pressure overload for the right ventricle? The conditions primarily are lung conditions, so COPD, emphysema, high blood pressure in the pulmonary vessels, which we call pulmonary hypertension. Those are the conditions that increase the pressure inside the right ventricle. And thirdly, the disease that can affect the right side of the heart is usually secondary to left ventricular failure. So maybe enlargement or cardiomyopathy, for whatever reason, can backflow and cause secondary right-sided heart failure. You know, there's a very close relationship, isn't there, between the lungs and the heart, the next door neighbours. And we've got a term for lung disease that causes right ventricular failure. And we call that cor pulmonale. Many of you have probably heard that term. That's lung disease that results in right ventricular failure. So it's all to do with back pressure. So when there's disease in the pulmonary vessels, that high pressure, that back pressure is transmitted to the right ventricle. And so ultimately it can cause right-sided failure, right-sided heart failure, or right ventricular heart failure. So pulmonary arterial hypertension, PAH is the abbreviation, is high blood pressure in the little pulmonary arterioles that lead from the right ventricle to the lungs. And when you get high blood pressure in these little vessels, that pressure, as we said, is transmitted back to the right ventricle, and you can end up with high blood pressure that's transmitted and is the cause of right ventricular failure. So pulmonary hypertension, that's the name that we give this condition, is an important complication of many of the common respiratory conditions that we see in clinical practice. So we commonly see patients with COPD. And with COPD, there's hypoxia, there's inflammation, there's a lot of things happening at cellular level or endothelial level. And the effect of that is high blood pressure, pulmonary hypertension, and if it's sustained, it'll be a cause of right-sided heart failure. So let's talk about how people present clinically with heart failure. there's 4 red flags clinically that if you see these in your patients, you know that you've got an unwell patient, a seriously unwell patient. So a red flag is always hypotension. So hypotension defined as a systolic blood pressure of 90 or less. If people's respiration rate gets above 25, that's a red flag. If their oxygen saturations drop below 88 to 90, you've got hypoxemia. It's a red flag. And anyone who's got a heart rate of 130 or above, they've got tachycardia, haven't they? Anything above 100 by definition is tachycardia. So these are red flags in the setting of heart failure. And like we said previously, with left-sided heart failure, it's all about back pressure from the left ventricle to the left atrium and then back to the lungs. So when the left atrium becomes full with volume and increased pressure, that's transmitted back to the left atrium. When that's full, it goes back to the alveoli and contributes to pulmonary edema. So pulmonary edema is essentially fluid in the little alveoli sacs. And that causes people to present acutely. So if you work in an emergency department or you're seeing patients in the community and they're short of breath, that's often what drives them to pick up the phone and call for help. It'll be what drives them to pick up the phone and call for an ambulance. It'll be what drives them to pick up the phone and make an appointment with their GP, is this acute shortness of breath. You know, when people come into hospital or they get assessed, often there's a heart reason for their pulmonary edema, isn't there? So these are all red flags. So if you're getting a history of a patient that's short of breath, these are red flags. So becoming short of breath on exertion and having a reduced exercise tolerance is a red flag. It's a red flag when you are talking to a patient and they're short of breath at rest. It's always a red flag if patients describe to you in their history, or you ask if they are able to lie flat at night to sleep. So if a patient can't lie flat at night to sleep without getting short of breath, we call that orthopnea. So orthopnea is a red flag in history taking. Likewise, if people describe waking up overnight, acutely short of breath, they have to sit up or get up out of bed to get their breath, we call that paroxysmal nocturnal dyspnea, P&D. They're all red flags. You know, I was on holiday last week and we went to visit the city here that many of you know. And I see there's people registered from Tauranga, and anyone that's been to Tauranga will recognise Mount Maunganui. And so I climbed Mount Maunganui on Saturday. And as I was climbing Mount Maunganui, I went past this on the way up. And that's a AED, that's a defibrillator. And at that stage, I was getting quite short of breath. I thought, wow, how come they've put an AED on this climb? Maybe they're expecting, maybe people have gone into acute heart failure, become acutely short of breath. Maybe they cardiac arrest going up this mountain. But, you know, when you get to the top, the view is worth it, isn't it? The beautiful city of Tauranga. But so in some cases, we're allowed to be short of breath. So if you're climbing Mount Maunganui, most of the people that I saw steaming up were short of breath. I was short of breath also, but you're allowed to be short of breath when you're climbing a mountain. But if you're talking to a patient getting a history and they're short of breath at rest, or they describe reduced exercise tolerance, remember those are red flags. So always be on the lookout for red flags when you're getting a history from patients. Because as health professionals, we have to be very careful we don't miss red flags when we get history. So remember your red flags for heart failure: shorter breath at rest, reduced exercise tolerance, orthopnea, P&D. What does it look like clinically when patients develop right-sided heart failure? That the back pressure goes to all the peripheral vessels and patients will get a raised JVP. So that's a sign of right-sided heart failure. They'll often get peripheral edema. That's a sign of volume overload in the peripheries. If you see someone with a big tummy like this could be air or it could be fluid, couldn't you? Couldn't it? And so what you've got to do is differentiate between fluid and air. So if this was air, when you percuss on the abdomen, it would be tympanic sounding. But if this is fluid, when you percuss, it'll be dull to percussion. So this is ascites, isn't it? Have you seen limbs? Have you seen legs that are just oozing the serous fluid? That's what you get with venous congestion. And it's a sign, all of these are clinical signs of right-sided heart failure. When you see these signs clinically, you never forget them. One of the maybe hardest or most challenging clinical examination techniques to master and feel confident with is measuring or assessing the JVP. So the height of the jugular vein is like a little barometer it gives us an idea clinically how much extra fluid patients have got on board and whether they're overloaded or not. So it is a difficult clinical skill to master. If any of you are beginning to do a patient assessment, I'd encourage you to persevere with it, get all the practice you can, because it is a very useful clinical skill to have in terms of volume assessment. What it does is it's as if you're peeling back the layers of the heart, and it now allows us to see inside the right side of the heart. It allows us to assess volume or fluid status of the right atrium. And so it's a very useful clinical assessment tool to develop. So what are the red flags for right-sided heart failure? The red flags are peripheral edema, raised JVP, a big tummy full of fluid, ascites, reduced exercise tolerance, and fatigue. You know, two of the most common symptoms that patients describe when they present with heart failure is a reduced exercise tolerance, so unable to do the same amount of exercise as they previously could without getting shorter breath, and fatigue. Some of you might be feeling fatigued now because you've stopped for lunch and you're listening to a webinar. So we can only imagine what that fatigue must be like for patients with heart failure. It must be even worse than what we feel at the end of the day. Let's talk about diagnosis. So for diagnosing heart failure in general, there's a few components. One is getting a patient history, and we've talked about the red flags that as health professionals we shouldn't miss in terms of identifying red flags. We've also talked about clinical assessment, and clinical assessment or physical examination is really important because you may not have access to echo, you may not have immediate access to a chest x-ray, you may not have immediate access to sending a blood sample off. So your assessment, your history taking and your examination findings are really important. So some of the clinical assessment that we do for heart failure specifically is listening to the heart and lung, assessing the JVP, and assessing for peripheral edema. If you've got access to a chest x-ray, that's very helpful, and we'll talk about the most specific blood test for heart failure a little bit more shortly. It's BNP. Let's just talk a little bit about lung sounds with acute heart failure. So if you've got a patient you think, I think they've got heart failure, I think they're presenting with acute heart failure, pick up your stethoscope and have a listen to their lungs. So the abnormal finding for acute heart failure, if people have got left-sided heart failure and that fluid is backlogged to the lungs, to the alveoli, and they're getting or developing pulmonary edema, what you'll hear is fluid. But, you know, we don't call it fluid, do we? When we're listening or examining, we call it crackles. So the old term for crackles is rales. So we used to say that a patient's got rales, but the new term is crackle. So a crackle is any fluid. So that fluid may not be a fluid related to heart failure specifically. It could be pus, it could be pneumonia. Whatever the fluid is, we term it crackle. In the setting of heart failure, what causes a crackle is the little alveoli sacs popping open when the patient breathes in on inspiration. So when the patient breathes out, the little alveoli collapse down. And then when the person breathes in, when they inspire, the alveoli just pop open. And that causes the sound that we call a crackle. Now, when you run your fingers through your hair, that's one way of picturing or visualizing what a crackle sounds like. Some of you may recognize this beach. It's a beautiful South Island beach. And if you recognize it, feel free to tap it into your question and answer function now. So this beautiful beach is Kaikoura on the South Island, and it's a stony beach, and as the water runs back over the stones, back into the sea, it makes this beautiful popping, crackling sound. So whenever I'm listening to lungs, I'm asking myself, can I hear any crackles? That's the sound I'm visualizing. You know, the other sound that is good to compare heart failure crackles to is, you know, that those little chocolate elves that you can buy, and you pop them into your mouth, and you taste the beautiful chocolate, and you hear all that popping sound. That's like a crackle. So that popping sound in your mouth as you savor the taste of a little chocolate elf, that's the sort of same sound that you're listening for someone in acute heart failure. But remember, heart failure always has a cause. So if you're a health professional and you're assessing a patient, as well as diagnosing heart failure, you also need to be thinking about what has caused the heart failure. And many of the tests and the investigations that we do on a patient presenting with acute heart failure is to also determine what the cause of it is. So these are commonly some of the tests and investigations that we do to help determine the cause. So we do blood tests, because often if people have had a myocardial infarction, that can cause people to tip into acute heart failure. So we measure troponin. If people have got elevated thyroid levels, that can cause a tachycardia, and that can drive someone into acute heart failure. If people are anemic, that can cause or contribute to heart failure. So one of the really important tests that the majority of us can do wherever we work clinically is a 12-lead ECG. So if you've done a 12-lead ECG, look for any ischemia, look for an arrhythmia, look for evidence of hypertrophy or an enlarged R wave in the chest leads. It's all evidence of maybe a cause for heart failure. Remember, if people have high blood pressure on ECG, that can be reflected as hypertrophy or a deep R wave, a very tall R wave. Sometimes if we suspect that coronary artery disease is the underlying cause, we'll refer them for a coronary angiogram. And sometimes we think, well, maybe the cause of the heart failure might be a valve problem, then we'll refer that person on to have an echocardiogram or an echo. So these are all of the tests and investigations, not only to confirm heart failure, but also to help work out the cause. Because if we can work out what the cause of heart failure is, then it'll help us manage or treat the heart failure. So this is another opportunity for to use your question and answer facility. So if you did a 12-lead ECG, or you were shown this 12-lead ECG, what would your thought be in terms of an arrhythmia? So I'll just give you 10 or 15 minutes. While you're writing down your answer, I just have to ask Pauline, for me just to see the questions pop up. Pauline, what do I press on my...
There's no questions. People can just use the Q&A function.
Yep, of course, it's got through left bundle branch. Yep. Any other one like to volunteer? So this is a really, yep. So this is sort of a common rhythm that we see in clinical practice. So it's actually atrial fibrillation. So this is fast atrial fibrillation, and often that will cause people to tip into acute heart failure. And clinically,
you're not showing your slide at the moment. You're on. There you go.
Cool. So rapid atrial fibrillation can present just like VT. It can fool us, and just the speed of it comes when we think what's going on. With this rhythm here, it's irregular, and that's probably the big clue that this could be atrial fibrillation. So commonly in clinical practice, when people go into rapid atrial fibrillation, that can lead on to acute heart failure. So a 12-lead ECG can be really valuable in terms of working out what the cause of heart failure is. I mentioned earlier, there's one blood test that's very, very specific for heart failure, and we call that blood test BNP, or it's B-type natriuretic peptide. So what does that mean? It's really a little hormone that's produced from the heart as the heart stretches. So as the ventricle stretches and dilates in response to increased volume and pressure, the heart's amazing. It releases a little hormone, a little protein, and we can measure that. And of course, we always have to give everything a name, don't we? And so we've named this hormone BNP, or B-type natriuretic peptide. So it's released from the ventricles as they fill up with fluid and stretch. And it's the body's way of compensating for increased volume. And what it does is that this little hormone, it acts on the kidneys, and it helps the kidneys to excrete a little bit of extra fluid. So it's the body's own compensatory mechanism to help clear a bit of volume. So if the level of BNP, we measure it in picograms per mil, it's sort of an unusual measurement, isn't it? But if it's sort of greater than 80, then it's very highly suggestive of heart failure. So normally we should have really no level of BNP in our blood. The value of BNP is that it has a very strong negative predictive value. What do I mean by that? I mean that if you think your patient might have heart failure and you do a BNP and it's normal, then it rules out. Normal BNP really rules heart failure out. It's challenging, isn't it? Because we've talked about some lung conditions already, haven't we? We've talked about COPD and there's emphysema, a lot of asthma, a lot of respiratory conditions that make people short of breath. So if you're assessing a patient and they're short of breath and you're not sure whether it's a lung condition that's causing it or a heart condition like heart failure, do a BNP. Because if your BNP comes back raised, it means that it's heart failure. If it comes back normal, it means it's not heart failure. So it's a very valuable rule out blood test. And our international heart failure guidelines endorse BNP with the highest level of evidence possible. And they say it's very useful to support clinical decision making and diagnosis to do a BNP level. You know, what's become very popular over the years is echocardiogram or echo, and it's reduced the need for invasive right heart studies where we would take people to the cath lab and put catheters into the right side of the heart and measure pressures. With echo, we get so much information. It's non-invasive, it's quick, but the problem is because it's so good, the demand for it has overwhelmed sort of our resources. And for any of you that are work in general practice, if you're a GP, if you're a nurse practitioner, if you're a clinical nurse specialist and you're requesting an echo, most places around the country, it's actually really difficult to get an echo because of demand and limited echo resources. So these are just some little tips. If you're requesting an echo as a GP or a nurse practitioner or a CNS, whatever your role is, if you're requesting an echo in the community, on your request, put comments on these little things here. So have a listen for a murmur. So if you've listened for a murmur and heard a murmur, write that down. That'll give your echo request priority. Be specific about their symptoms and remember to document any red flags. So if you've got orthopnea, P&D, document those red flags on your echo request. It'll help gain a little bit of priority. If you can do an ECG, do an ECG, because if an ECG is showing hypertrophy, so increased voltage, then that's also adds priority to your echo request. If you've got reasonably easy to do a chest X-ray, do that, because if that comes back showing that there's evidence of heart failure, that'll give priority to your echo request. And lastly, do a BNP, because if that comes back raised, you can put your BNP result on your echo request. So these are just some little tips and tricks. And these have come from our echocardiologists. So they told me that if an echo request has these things on it, they'll prioritize it. So it fast tracks your echo request. So this is sort of inside information that I'm sharing with you in terms of getting your echo request prioritized. Echo might be quite new to some people listening, and I never like to assume anything. So for echo, what we are able to do is assess the atria and the ventricles. We're able to look at the valves, but really importantly, we're able to assess pump function. And remember, we said right at the start that heart failure is reduced pump function. And like we mentioned earlier, we can measure how much blood is pumped out of the heart in one beat. We express it as a percentage and we call it ejection fraction. When the left ventricle beats or pumps, there's approximately 100 mils of blood in the ventricle. But when the left ventricle pumps, it doesn't pump out all of that 100 mils. It only pumps out about 60 to 80 mils. So we consider a normal ejection fraction or normal pump function to be about 60 to 80%, sort of 60% is pretty common for a normal value. So nobody ever scores 100% with ejection fraction. I'm going to play you just two echo pictures here. They're going to move side by side, and the echo picture on the left is a normal heart, and the echo picture on the right is a patient with heart failure, where the whole heart is enlarged. And remember what we said right at the start with heart failure, the heart, the left ventricle, and also the right ventricle in many cases, it becomes bigger, thinner walled, and weaker. And we see this in echo really well. You know, if you were to look at a textbook picture of the heart, in any textbook picture, we see the atria at the top and we see the ventricles at the bottom, don't we? But when we look at an echo, everything's around the wrong way. Everything's upside down, which makes it really challenging. So I'm going to make this play now, and I'm going to talk through what we're looking at. So if you look at the echo picture on the left, this is a normal pump function. This is the left atrium. So bottom right is left atrium, top right is left ventricle, bottom left is right atrium, and on the top, on the left, is the right ventricle. So the ventricles are at the top and the atria are at the bottom. So we can see very well the valve. So this is the valve on the right-hand side here. This is the valve that goes between the left atrium and the left ventricle, and that's the mitral valve. On this side here, on the left-hand side of the heart, on the echo picture, we see the valve that goes between the right atrium and the right ventricle, and that's called the tricuspid valve. So we did a very good look at the valve function. All this grey colouring here, that's actual muscle, and we can see in this picture on the echo picture to the left. I'm just going to go back and replay that. The heart muscle is actually moving right down to the bottom of the heart, and we call that the apex of the heart. So this is normal pump function. If you look at the heart on the right, you can see the heart isn't really pumping. That the heart, sort of the bottom of the heart here, the apex where my little cursor is really just rocking. It's not really pumping. The size of the left ventricle here is huge. The size of the right atrium is huge. So this is a patient with heart failure. If you were to measure how much blood is being pumped out in one beat, it would be probably 20% or less. So the whole pump function is severely reduced. So this is what we see when we look at echo for a patient with heart failure. So you can see when we look at echo, it's very easy to see what the nature of heart failure is, how bad it is, whether it's the left or whether it's the right, whether it's both. And we also see potential causes. So if there was a valve abnormality, we would see that very clearly on echo. If you're doing clinical assessment on a patient in the community or in a hospital setting, you will hear a murmur, but you won't be able to know what valve it is, whether it's right or left. So that's why it's really important to refer on for an echo. Helps to find what the exact nature is. And remember, if you know the cause of heart failure, then we can often treat heart failure. So if we know it's a valve problem, we can do valve replacement. If it's a muscle problem, we can do medicines for that. So echoes become very, very important to us. You know, I just have to share one thing with you briefly. We've got a brand new way of classifying heart failure. We've talked about right-sided and left-sided heart failure. The new classification is by using the ejection fraction to classify it. So we can't classify people according to this unless people have had an echo. So remember, it's by echo that we know what the ejection fraction is. So the two ways that we classify people or heart failure now is heart failure with a reduced ejection fraction, and that's defined as being less than 40% ejection fraction, and those people that have a relatively normal ejection fraction, and we call that preserved ejection fraction, and that's defined as being 50% or above. So if you're looking at a patient with heart failure and they haven't had an echo, you won't really know what box to put them in, will you, at this stage? But your patient will be either a HEF-REF or a HEF-PEF. So that's the in terminology. HEF-REF, heart failure with reduced ejection fraction, or HEF-PEF, heart failure with preserved ejection fraction. So it's brand new classification. We're learning a lot about this heart failure with preserved ejection fraction, and it seems to be caused by comorbidity. So if your patient's got a history of high blood pressure, obesity, atrial fibrillation, diabetes, coronary artery disease, these are all comorbidities that we're often familiar with. That seems to cause the ventricle to stiffen, and it causes increased diastolic pressures and heart failure, where the heart's able to pump well, but it won't relax. And that's really what heart failure with preserved ejection fraction is normal pump function, but the heart can't relax during diastole. So HF-ref on the left, where you get big dilated ventricles. Your HF-pef is on the right, where the muscle gets a bit thicker, and so the heart can't fill as well as it should. You know, the interesting thing, what we've found, we've done a lot of research on heart failure, but we've found that patients with HF-pef don't respond to our usual medicines. So we've got really good evidence-based medicines for heart failure with reduced ejection fraction, but these medicines don't seem to improve outcomes. They don't improve mortality to the same extent as HF-ref patients. In our Cardiac Society guidelines for HF-pef, preserved ejection fraction, all they can tell us to do is to take attention of comorbidities. So treat with diuretics, manage comorbidities, i.e. high blood pressure, atrial fibrillation, diabetes. So not very helpful, is it? So how do we manage heart failure? You know, we juggle lots of things, and management of heart failure, management of congestive heart failure is juggling. So I'm just going to go through some of the things that we juggle. So we juggle oxygen, we juggle volume, and we call that preload. We juggle contractility, we juggle heart rate, and we juggle afterload. Have a quick look at each of these. For patients where they present with pulmonary edema, fluid on the lungs, we juggle that management by giving people oxygen with a bit of push or flow behind it. And we call that CPAP, continuous positive airways pressure. It's life-saving because it pushes fluid out of the alveoli back into the capillaries where it belongs. We have to put a pretty tight fitting mask on people, and you'd sort of think it's counterintuitive, but having a tight fitting mask and having a bit of pressure behind the oxygen we give, it actually decreases the work of breathing. And that's because we're pushing fluid out of the alveoli back into the capillaries. It's usually done in a high dependency area. This is our coronary care unit at Christchurch Hospital. You know, we can juggle volume, can't we? If we need to increase preload or increase fluid, we can do that through giving people IV fluids. But usually in the setting of acute heart failure, congestive heart failure, we're actually wanting to take fluid away. How do we do that? We give diuretics, don't we? Furosemide is the most common loop diuretic that we use in clinical practice, and we can offload fluid. The other way that we can influence fluid or reduce preload is by giving ACE inhibitors. So ACE inhibitors block the production of aldosterone, which in turn reduces sodium production and therefore fluid production. It's pretty complicated, but the body senses a low blood pressure, and so it blocks this little enzyme that would otherwise act on the adrenal cortex. And so it's all about, as we said, reducing aldosterone. So if you can reduce aldosterone or salt production, you'll reduce fluid and water. You'll reduce volume. The easy way of remembering it is salt sucks. So sodium sucks out water. If we can reduce aldosterone production, that in turn will reduce sodium and therefore water. So ACE inhibitors, some of the ACE inhibitors that we commonly use, probably the most common one really is cilazapril. You know, when you blow a balloon up and you leave it in the corner for a few days and you come back to it, it looks a bit like this, doesn't it? It all goes baggy and saggy. And, you know, with heart failure, that's what the left ventricle becomes like. It becomes like a baggy, saggy muscle. So it's lost all that muscle tone and it becomes big, thin, and weak. It becomes baggy and saggy. And, you know, there's only one group of medicines that put tone back into a baggy, saggy left ventricle, and they are ACE inhibitors. So your ACE inhibitors that you prescribe for your patients and that you administer to your patients are what make the difference to improving pump function, improving muscle tone. You know, we can also juggle contractility, and this is done in a hospital setting. We can give infusions of inotropes, medicines that improve contractility. So some of those names that you'll be familiar with are dobutamine, dopamine, adrenaline even, levosimendan. These improve pump power, but they have to be given through IV infusion. At the high end of technology is we can put catheters inside the aorta that rest the left ventricle. So balloon pump technology for people in acute left ventricular failure is sometimes appropriate. One of the key ways of gaining control over heart failure is control of the heart rate. Remember, we said at the start that having tachycardia is a red flag. So a really important part of heart failure management, congestive heart failure management, is juggling medicines that control or reduce the heart rate. So beta blockers are often our first line. Metoprolol, if people can't tolerate a beta blocker, the digoxin is another really good common rate control medicine. Digoxin's got the advantage is that it also strengthens contractility. So you're reducing heart rate and improving pump power all through the same medicine. These are just some of the things to consider with beta blockers and ACE inhibitors. We often start low and titrate up because both of these groups of medicines can cause low blood pressure. They can cause heart rate to go down a little bit too far. ACE inhibitors, we also have to monitor renal function, potassium level. This is a nice little simple analogy. This donkey here is a little bit like the heart, and it gets tired of pumping all this volume. So this donkey has to pull around this wagon load of sacks. How do we make it easier for it? We can take off some of that load and make it easier for the donkey. That's what we do for patients when we give them diuretics and when we give them ACE inhibitors. We're reducing preload. Beta blockers, when the heart goes slower, it conserves energy, and that's what we're doing with beta blockers. These are just some little practical tips. If you've got a patient and their blood pressure's a bit low, because often if people's blood pressure are low, it stops us giving the medicines that they need. And that's a bit of a dilemma, isn't it? Sometimes if we do a manual blood pressure, we can get a slightly higher blood pressure. But what we have to do is assess blood pressure trends from previous doses. You can consider giving half a dose, or consider splitting blood pressure lowering medicines, and maybe a diuretic in the morning with a beta blocker and ACE inhibitor later in the day. So there are things that we can do to sort of juggle and enable us to still give the medicines that are really important. Sometimes blood pressure, renal function, potassium levels, they can all sort of add to the challenge. The kidneys and the heart have a very close relationship. I just wanted to share very briefly with you one brand new medicine on the heart failure field. I'm not going to go through every slide. It's one called Entresto. What it does, or what it's indicated for at least, is patients that have got reduced ejection fraction, so our HF-ref patients. It replaces an ACE inhibitor or an angiotensin receptor blocker. Very good evidence to show that it reduces hospitalization and death. But what it does is simply it helps the goodies and it blocks the baddies. And in the heart, the goodies are the things that promote vasodilation and promote diuresis, and the baddies are the things that cause vasoconstriction and cause patients to retain sodium and water. So it helps the good things and it blocks or inhibits the bad things. Just some practical prescribing tips. It comes in 3 strengths. We usually start people on the middle strength, and titrate up after 2 to 4 weeks if the patient's tolerating it okay in terms of blood pressure. Shouldn't be started while patients are taking an ACE inhibitor or an angiotensin receptor blocker. We do need a 36-hour period of washout between the two. The biggest challenge or side effect is low blood pressure. So if it drops people's blood pressure too much, then we have to maybe consider reducing the dose of it. In the last 2 minutes, I just want to touch on patient education. We've got wonderful resources through the Hart Foundation in terms of heart failure education. These 3 things here are the most important things in terms of patient education. Getting the patient to weigh themselves each day and to record their weight, checking for ankle swelling, checking for any change in breathing. So the weight is about getting the patient to weigh themselves first thing in the morning, get them to go to the toilet, then hop on the scales. And it's about having an action plan. So if people's weight goes up or down by 2 kilograms in 1 to 2 days, they need to contact their health care provider or GP. So it's all about self-care in the community. So a really simple thing to do, but really importantly, it helps people to monitor their own heart failure status. So it's all about really encouraging pump function, isn't it? And having a stronger pump. And that's done largely through medicine, but also lifestyle factors. So thank you very much for listening this afternoon. Stay safe. I'm happy to take some questions just in the last few minutes.
Thank you, Murray. I've just put in a bit of a reminder for people to send you some questions. Can you see them yourself?
Yes, yeah.
There's only one, I think, there at the moment, and it's about when were the upper chambers of the heart renamed from auricles to atria?
Yeah, it's a good question. I couldn't actually tell you when that was. Some of these terms are still used sort of a little bit interchangeably. And so you still in some cases see auricle, but predominantly now we use the term atrium. It's a very good question, and I don't really know the answer to it, when it was renamed or why it was. It's one of those things that probably is done to confuse us. Cardiology is really bad for lots of different names just to confuse people.
And can you see that other question that's come in? Could you show the goodies and baddies slide again?
Yeah, cool. So why don't I just go back? I do apologise, I jumped over that fairly fast because I was really worried I was running out of time desperately. So let's go back. So there are goodies and there's baddies in terms of the heart. And so the goodies, so these are the goodies. These are the hormones that the heart produces itself. And remember we said that BNP is one of the goodies, and that's produced in response to stretch. So it's all about hormones. So we've talked about BNP, but there's also a hormone that's produced from the atria, and it's called atrial natriuretic peptide. So ANP, urocortin is another one that we don't hear so much about, but they're all hormones that help produce vasodilation. And through vasodilation, it causes sodium to be excreted, and with that will go water or volume. So the baddies are also produced by the body. So we've talked about aldosterone that causes vasoconstriction, some of the inotropes in the body, noradrenaline, adrenaline, vasopressin, they're all things that the body, hormones or chemicals that the body produces itself in response to that low blood pressure. Remember, the body just sees low blood pressure. And so it produces all of these things here, aldosterone, noradrenaline, angiotensin, vasopressin, endothelium, to help keep the blood pressure up. But of course, in the setting of heart failure, it's not helpful, is it? So it blocks the baddies and promotes the goodies. And there's a similar slide, this one here I'll just talk about, so that the two components of Entresto, one component of it enhances the beneficial effects, and the other component of Entresto inhibits the renin-angiotensin cycle. So it's the equivalent of like your ACE inhibitor. So the advantage of Entresto is it really does the same as what an ACE inhibitor does, but with the extra of benefit of enhancing the beneficial hormones within the body. I didn't have time to say it before, but I'll say it now. It does have to be applied for special authority. You don't actually need an echo to apply for special authority with Entresto now. That was brought in during COVID times last year. So Entresto is new-ish. It's been around for maybe 2 to 3 years. It's a very, very good medicine that you should consider for your patients if they tolerate it with the blood pressure.
Right. Can you see the other question that's come in there, Murray?
So let me see.
What was the cardinal sign to watch out with the elderly resident to identify heart failure?
Yes, so increasing shortness of breath really is the cardinal sign. And so for elderly patients in a community setting or aged care setting, they'll become increasingly short of breath. They'll be able to walk less distance without getting short of breath. So they may get short of breath even walking from their rest home room to the dining room table. They will develop an inability to lie flat at night, orthopnea. They may even wake overnight feeling short of breath. So those are the red flags. If you were weighing your patient, you might also notice an increase in weight. I know where my mum is, the rest of the time they just weigh them once a month, so that might be more difficult to pick up. But shortness of breath is really the one cardinal sign just to watch out for.
Thank you. On the chat functions, Luke has asked, he says he's just wondering how useful portable ultrasound like the Butterfly IQ will become.
Yeah, it's a very good question. We have a portable ultrasound available to our doctors. I guess the caveat is you've got to know how to interpret it. So being portable is great, but you've got to be able to interpret the pictures that you see. What do we use it for in a hospital setting? We use it in a hospital setting often during clinical emergencies. It's very, very good for assessing left ventricular function, pump function. It's very, very helpful to assess whether the patient has got tamponade, where there's a buildup of fluid around the heart that could be causing a clinical emergency. So it gives you good, broad information about LV function, pump function. Very good for identifying any life-threatening cause of a clinical emergency. I think they're wonderful to have, and as long as you've got the skills to interpret what you see, very, very valuable. Yeah.
And as long as you can afford it as well, I suppose.
Yes, absolutely. Yeah, equivalent of portable ECG machines, really wonderful.
Yeah. Okay, I think we've run out of questions, Murray. The last comment is somebody asking that you could please come back at least every 3 months because you're such an excellent presenter. So just put that on your evaluation, Mary Cutter. And I think it just remains me to thank you all for attending and joining in today. We got up to 240 people today at one point.
Yes, I saw 250 at one point, actually. Yeah.
Oh, wow, 250, well done. And it certainly was a really interesting presentation that obviously hit the spot. Lots of thank you messages. So thank you from me too, Murray.
Thank you very much, Pauline. Thank you. Yes, thank you very much. Thanks for all your positive feedback.